Hello, everyone, and welcome to today's Keynote webinar titled Advanced Imaging for Small Renal Tumors. This webinar is a part of the 11th annual event in the Cancer Research and Immuno-Oncology Week virtual event series. I'm Cassie Soltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to first participate by communicating with other attendees using our live chat feature during the presentation. You can find the live chat located at the bottom left of your screen. If you have trouble seeing or hearing the presentation, click on the Help Desk button from the lobby within the event. Finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits image located on the right of your screen and follow the process to obtain your credits. Now let's get started. I now present today's speakers, Li-Ming, Secretary General, Endo-Urological Society, Pete and Carolyn Newsome, Professor of Urologic Oncology, Chair, Department of Urology, University of Florida College of Medicine. For a complete biography on our speakers, please find it to the left of the screen. Li-Ming, you may now begin your presentation.
Hello, my name is Li-Ming Su. I'm the chair of the Department of Urology at the University of Florida College of Medicine. I want to first start out by thanking the LabRoots collaborators and team for inviting me to speak to this diverse group of individuals today and about a subject matter that I'm very passionate about. As a urologist that has been in practice for 24 years, the subject matter of managing and assessing and categorizing patients that have small kidney tumors has been something that's been very fascinating to me. So today, what I'd like to share with you is some of the advanced imaging technologies that are coming down the pipeline to help us as urologists and physicians and clinicians assess small kidney tumors, or what we call small renal masses. By way of disclosures, I have no disclosures relevant to this presentation today. The objectives of my talk are threefold. Number one, to recognize the relatively high incidence of benign kidney tumors found following kidney tumor surgery for small renal masses. Number two, identify the limitations of current conventional cross-sectional imaging in characterizing these small kidney tumors. And number three, describe how new advanced imaging modalities may in the future help predict tumor phenotype and thus reduce the number of unnecessary treatments for benign or even low-risk kidney cancers. As urologists, the cornerstones of our diagnostic imaging tests really rest on four things: ultrasound of the abdomen, CT scan, which is a type of cross-sectional imaging, and MRI scan, also another separate type of cross-sectional imaging. And increasingly, we're using PET scan imaging for certain types of urologic cancers. However, this particular slide really encapsulates the current dilemma that we face, which is how do we assess the small renal mass, really defined by solid renal tumors less than 4 centimeters. So these are not the cystic renal collections that are generally considered benign. These are solid tumors. And, you know, our radiology colleagues typically on their report, and this is an example of what we would get, is on a CT scan report, would define this as a 3 centimeter solid enhancing renal mass of the right kidney, concerning for renal cell carcinoma or kidney cancer. Makes sense, right? When you hear the word tumor or mass, naturally, you know, the instinct is that we think about cancer. And, you know, the American Urology Association uses the criteria of defining a solid enhancing mass by something called enhancement. So on a CT scan, the mass actually gets brighter when you administer intravenous contrast dye, suggesting that the mass has blood supply that's feeding it. So this is then considered a tumor of some sort. And naturally, we have patients coming in with this diagnosis, and they're fearful that they have a bad case of a kidney cancer and that their life is in jeopardy. But as urologists, we know that small renal masses, or SRM, are really a very heterogeneous group of tumors, many of which are cancers, but some of which are benign. And in fact, the World Health Organization recognizes well over 14 unique subtypes of kidney cancers. And you can see on the left side of the screen the three most common types of kidney cancer: clear cell, papillary, and chromophobe. But also there are benign kidney tumors, angiomyolipoma and oncocytoma. Now, throughout the presentation, I'm going to be emphasizing the term clear cell renal cell carcinoma. That's the tumor on the far left, as this is the most common, but also the most aggressive kidney cancer. And then I will also be mentioning oncocytoma, which is on the far right, which is the most common benign kidney tumor. And even beyond the subtypes, we know there's a very profound genetic basis of kidney cancer that really informs us about the biology, if you will, of the disease, and also has helped us formulate treatment options based on this genetic basis. But back to our conundrum. Our conundrum that we face is small renal masses that are identified most commonly on CT scan and MRI have variable malignant potential. What I mean by that, as urologists, we are the physicians that receive these patients and operate on these patients. And when we remove these tumors, about 80% of these are in fact cancerous. But what I want to focus on is up to 20% of these are actually benign. And if you look at the tumors less than 2 centimeters, that can increase to about 40%. So you can imagine a fair number of patients are undergoing invasive treatments and surgeries despite having a benign tumor that would never cause a problem for them in their lifetime. And even furthermore, if you look at the cancerous subtypes, a fair percentage of them are low-risk tumors, and only 20% have high-risk features. Now, one may say, are there clinical parameters that can help sort out which are benign versus malignant? So, for instance, there are studies that suggest that female gender seems to correspond more to a higher percentage of patients having benign tumors, lower body mass index, or smaller tumors, as I mentioned before. But obviously, these clinical parameters are really not reliable enough to identify which are cancerous versus benign with 100% accuracy. So if you go to the American Urology Association guidelines for small renal masses, there are 4 different treatment options. On the far left, partial nephrectomy. That's removal of part of the kidney that contains the mass and not sacrificing the entire kidney. Number 2, radical nephrectomy. That's removal of the entire kidney. Number 3, thermal ablation. This is where we can actually capitalize on using less invasive means of treating tumors rather than surgery. So these are done by interventional radiologists, where they can pass small needle or probes through the skin into the body, into the tumor, and actually freeze or heat these tumors essentially without making an incision. And lastly, there's active surveillance for patients that are frail. So these are guidelines that are standard management options that are provided to patients. And these are all under the auspices of the AUA that say that these are reasonable options for those patients that present with small renal masses, depending on their age, life expectancy, and health. However, the bottom line is, how well are we what we call risk stratifying? Are we really identifying who really needs a radical nephrectomy? That's complete removal of the kidney, or partial nephrectomy, or thermal ablation, or active surveillance. And I'll say currently that the current state of affairs is we are not doing as much as we could, but that's based on the limitations of imaging, and that's the subject matter of today. To add to this, there is a rising incidence of patients undergoing partial nephrectomy. In our field, that's good. That means we're removing only the tumor, not sacrificing the entire kidney, because the kidney function in our bodies is so critical to our overall well-being that saving as much kidney as possible is important. So if you see the dark line at the top, year by year, we are doing more partial nephrectomies, which is good. However, in lockstep, we see the benign tumors that are being removed increases as well. And that's because of the limitations of our current imaging tests. Now, one may say, is there cost to overtreating benign tumors? And the answer is certainly there is. This is a study by Wynn et al., national inpatient sample looking at trends between 2004 and 2014 of close to 84,000 patients. Now, 7,100 underwent surgery for benign renal masses. So that's still a sizable number of patients having, in retrospect, an unnecessary treatment for a tumor that never needed to be removed. But here's the take home. Of the benign tumors, 44% of those patients underwent a radical nephrectomy. That's complete removal of the kidney for a tumor that's benign. Now, had we known that, of course, we would not have done that. But obviously, with the limitations of imaging in the current cross-sectional imaging that we use, it's not sensitive or accurate enough to tell us which are benign versus cancerous tumors. And then furthermore, the dollar cost is enormous. So in 2014, if you add this all up, that was $153 million of inpatient hospital costs. That's roughly $55,000 per patient. But we as urologists do enjoy doing surgery, right? We are trained to do surgery and remove tumors and cure patients. So we do a lot of what we call robotic partial nephrectomies. But if you look at this data from the NCDB data of close to 53,000 small renal masses that were treated, segregating them in terms of what types of treatments, I want you to focus on the bottom two colors, the red, which is robotic partial nephrectomy, and the blue, which is what's called active surveillance, which is simply a monitoring process in patients that have indolent tumors or tumors that we think would be too high risk to undergo a surgery or intervention because of an elderly state or comorbid medical issues. And we see that surgery is outpacing active surveillance. So again, we have seen an increase in robotic partial nephrectomies, and that's better than removal of the entire kidney. But knowing now, in retrospect, what we know, since 30 in some studies, higher percentage of patients have benign tumors, we should ideally see an increase in active surveillance and a steady state or a plateauing in the surgeries that are being performed. Now, we know that there's a condition of the body where we can do biopsies, whether it's biopsy of the lung, biopsy of the breast, biopsy of the liver. Why can't we biopsy the kidney? And the answer is yes, we can. However, there are shortcomings of a renal mass biopsy that I'm going to go into. And historically, the concern of putting a needle into a tumor of the kidney that is possibly cancerous runs the risk of complications such as seeding the tract with cancer cells. So for decades, this has been a procedure that has been shunned and avoided due to concern of risk of cancer spread. However, given this current dilemma of identifying what small renal masses really need to be treated, the idea of renal mass biopsy has come around again. And so this is a scheme that was devised by the University of Michigan, which would say if we did a biopsy and the current biopsy scheme that is used, which I'll go into shortly, can we identify which are benign or those that have favorable characteristics, meaning less aggressive features? Could those undergo active surveillance versus intermediate tumors that are larger or unfavorable tumors that have higher risk features undergo treatment? And those that are indeterminate, meaning we do not get enough tissue, undergo a repeat biopsy. Well, the natural question is, does biopsy alter treatment? Now, this is a study by a group at Henry Ford. This is a multi-institutional series, but headed by the Henry Ford group, where they retrospectively applied that scheme to close to 1,200 patients that underwent a robotic partial nephrectomy. And they identified if they applied that particular scheme to this particular set of patients, that close to 50% of patients could have potentially been reassigned to a more conservative treatment. So again, this is really suggesting that if we did know ground truth what these tumors were ahead of time, that it could assign a fair number of patients to a less aggressive intervention. Now, I mentioned problems with biopsy. So kidney mass biopsy has particular problems. Number one, sometimes the tumor in the kidney is in a location that it's difficult to access. So trying to put a needle into the tumor is not always easy because it may be in a precarious position or near adjacent organs that may be at risk. Number two, even despite getting a biopsy, there's a non-diagnostic biopsy rate of up to 20%. And that's no good. So a patient goes through an intervention and then we still don't know what it is, of up to 20%. Third, there's a condition called oncocytic neoplasm. So this is a sort of a gray zone, if you will, between what could be a cancerous tumor versus what looks to be similarly a benign tumor. So sometimes they give us an intermediate result or indeterminate result rather, and we have to try to interpret, well, again, is it cancer or benign? So that is also something we see not infrequently. Number four, there is a situation where we can get tissue and tell us what subtype, but it doesn't tell us how aggressive it is based on the tumor grade because of the limited tissue that they have to analyze. Lastly, there are complications, 1% complication rate, bleeding percentage rate of 5%. And I mentioned before, cancer tract seeding, albeit very low risk, is still a risk nonetheless. And that certainly relates to a lot of patient anxiety of undergoing a biopsy. So to get to the meat of the talk, though, here's the opportunity. The opportunity is that if you look at cross-sectional imaging in terms of resolution, and what we really want to know, which is ground truth histology, there is a significant chasm that currently exists between imaging and ground truth histology. And I think this is the opportunity that we have right now that really requires further work. And I'm going to go into some of the current imaging modalities that may fill the space. So we're going to talk about three things. Number one, cross-sectional imaging advances. And then number two, molecular imaging. And then lastly, optical imaging. So these are new imaging technologies that may help fill the space and answer the dilemma that we're facing. So cross-sectional imaging. This is some of the work that we became interested at UF Health Chance Hospital here in Gainesville, Florida. And this is on the heels of some work done by Joe Graho, which is the second author of this paper, called Aorta to Lesion Attenuation Difference. So on a CT scan, and the most common CT scans that we have multiple phases of imaging. They get a non-contrast phase that is just a plain scan of the body without administering any intravenous contrast. And then they do a contrast-enhanced phase, and they do a delayed phase. So they get multiple phases to give us different looks of organs within the body during the before and during and after contrast administration. That allows us to look at brightness, if you will, of different organs. So Hounsfield units is a radiologic term that measures the brightness of tissues. So if you look at the Hounsfield units of the aorta, which is the large artery feeding the organs in the body, and you measure that and you subtract away the brightness or Hounsfield units of the tumor, they curiously found that they can identify that the tumors that were less than 25 in the difference called ALAD, aorta to lesion attenuation difference, were highly representative of those tumors that were oncocytomas, which were the benign tumors that I mentioned earlier, versus the ones that were higher than 25, more characteristic of chromophobe kidney cancer. So if you remember, I said that on biopsy, we sometimes will get that ambiguous diagnosis called oncocytic renal neoplasm. So this is really to determine, could they use this particular nuance, or if you will, this scoring system or subtraction system on CT scan, which is a very simple methodology, looking at different characteristics of enhancement patterns between these types of tumors. Can we differentiate that by normalizing it to the aorta and simply identify whether that number can sort out the benign versus the cancerous ones? And they felt that this could accurately do that. And if you look at the performance characteristics, it performed extremely well sorting this out. Well, Dr. Graho, we were fortunate to recruit him at the University of Florida, and then we began to say, well, can we apply that to a larger series of patients who underwent robotic partial nephrectomy? So these are patients of mine who underwent robotic partial nephrectomy, about 230 cases, and we calculated ALAD retrospectively on the CT scans that they had. And again, found that if we reference the ALAD values to the pathology, the ground truth results, we found that again, below 25, you can see oncocytomas clustered in that range. And again, the whole concept of this is it capitalizes on these kidney tumors get brighter after contrast administration in a different manner. So those that get brighter quickly, if you subtract that from the aorta, the value is very low. Those that brighten up or enhance slowly or less avidly then have a lower number, and therefore the ALAD value is much higher. And so this is the principle behind using ALAD to sort out those that are benign versus malignant. So although it's good at separating particular benign tumors from cancerous tumors, when we start looking at the benign tumors versus the most common kidney cancer, which is clear cell, we found, unfortunately, there was a very low negative predictive value. And ultimately, as I went, if we reflect back on the question I was asking, is that ultimately we want one test that really tells us the subtype of all the different tumors that can then allow us to stratify who needs treatment and who can undergo a more conservative option or who needs active surveillance. Now I'm going to move on to a separate concept, and this is not CT scans now, that we're going to go into the discussion of MRI, magnetic resonance imaging. So this is a very complicated slide, but really basically saying that can we, on MRI, using more modern MRI techniques of different variations of imaging tests, looking at microscopic fat, segmental enhancement, arterial to delayed enhancement ratios, restriction diffusion weighted imaging. So a lot of different characteristics that the radiologists use. Can we use that to predict which small renal masses are the cancerous ones, and the most common one, clear cell renal cell carcinoma? So different from ALAD, when we were trying to look at the most common benign tumor, we're trying to look at, can we identify which are the most likely to be the clear cell kidney cancers? So with this complicated scheme, they identified a scoring system. It's like a Likert scale of what is likely to be a clear cell renal cell carcinoma based on these different parameters. And they found that using the 3-parameter signal intensity on the T2 weighted imaging being high, showing heterogeneous signal compared to the normal kidney, looking at enhancement pattern, that the tumor is avidly enhancement compared to the cortex, and the presence of microscopic fat. If they use those 3 parameters, they found that they can develop a Likert scale of the probability of this being a clear cell kidney cancer. And if you look at Likert scale 1, very low risk of this being a clear cell kidney cancer, versus a 5, which is 93%. So it really nicely stratifies that. However, when they applied that to a larger clinical series, if you looked at 1s and 2s that you would expect to be non-aggressive cancers or even benign tumors that could be considered for active surveillance, in the end, about 18% had high-risk cancer. Also, if you look at the 3s, then maybe we consider, okay, well, this is sort of in between. Maybe we need a biopsy. About 40% of them had the benign oncocytomas. So again, not perfect, right? But if the ones that were high 4s and 5s, you'd say all of these are going to be clear cell kidney cancers. About 10% were benign. So, although it did move the needle I think, in the right direction in identifying those that may be clear cell kidney cancers, it's clearly not a perfect test, but certainly thought-provoking. So the limitations of cross-sectional imaging is that there is a reader, or if you want to use the word human dependency to this, and that's hinting at, we're going to talk about some, computed algorithms or artificial intelligence algorithms. There's a reader dependency to cross-sectional imaging. Also, there are multiple variables and imaging phases that need to be read that increases the complexity of the study. And then the question is, what regions of the image are we actually analyzing? Because all these tumors have some degree of heterogeneity. So some broad spots, some dark spots, some areas of necrosis. And so what areas do you sample to determine what the tumor is a limitation of these cross-sectional imaging. And lastly, there's inter-observer variance. Now, so we talked about looking at small areas of CAT scans or MRIs. How about if we took the entire tumor and looked at the entire texture, if you will, of the tumor? And so this is the concept of MR textural imaging, okay? And the question is, can whole tumor MRI using digital textural analysis, and this is the concept of what we call radiomics, and this gets into sort of, again, the idea of artificial intelligence looking at a lot of data and looking at the entire texture of or data stream of the tumor. Can that help decode the tumor phenotype? And this is a very interesting study where they utilize advanced quantitative assessment using a combination of two things. One's called tumoral histogram, and this is really in essence the type of enhancement, and then textural analysis that gets into sort of the AI realm, were useful in differentiating small renal mass subtypes. And you can see in the table oncocytoma versus renal cell carcinoma, or oncocytoma versus specifically the clear cell renal cell carcinomas, and then the papillary kidney cancer versus clear cell, which is the most common kidney cancer type. So you can see the performance characteristics are fairly good, not perfect, but also fairly good. So this is a glimpse into where I think cross-sectional imaging will move into in the next 5 to 10 years, is relying upon image analysis, whole tumor image analysis to decode tumor phenotype. We at our institution at the University of Florida are fortunate to have one of the fastest academic supercomputers from NVIDIA. We call this Hypergator. And we also have begun to look at AI and machine learning to apply this to data sets to see if we can segregate those that are malignant versus benign. And preliminary data suggests that when we use a combination of clinical factors, again, remember at the very beginning we talked about certain patient characteristics may lean us toward what may be a benign tumor versus cancerous tumor. But we add that to radiomics using our algorithms, we feel like that began to show the best performance characteristics in sorting out those that are cancerous versus benign. So I think more to come on this, and I think this is the way cross-sectional imaging analysis will go in the future that will really provide more data to the clinicians. Now I'm going to move into molecular imaging. Molecular imaging, what's the concept behind this? This is the use of targeted probes for functional and or molecular characterization of cellular processes or compartments within cells. And we can use small molecules, antibodies, or peptides to use these as the probes that we're targeting within the cells. And these probes can be labeled with radionucleotides that really allows us to detect these with modern imaging, whether it's PET scan imaging or single photon emission CT, or which is called SPECT. So one very, very unique study is something that came out of Johns Hopkins by Mike Gorin and Mohammed Alaf back in 2016, capitalizing on the concept of sestamibi. So sestamibi is a lipophilic cation that accumulates specifically in cells that are rich in mitochondria. And we know that this is currently being used in heart imaging and parathyroid imaging quite commonly. But it just is so interesting that benign tumor, what we talked about before, renal oncocytomas, are uniquely rich in mitochondria, very different from the other subtypes of kidney tumors. So, uniquely, since they have a lot of mitochondria, we can capitalize on this. And if these mitochondria will take up the sestamibi, could we use this as a scan to identify those are renal oncocytoma? And their preliminary data actually shows that we can. So the question that they sought out was, can sestamibi SPECT select out oncocytomas? And another low-grade low-grade cancerous tumor called hybrid oncocytic renal neoplasm for those that are highly malignant. And using a cutoff of 0.6 on the sestamibi relative uptake value, they found that those that had cutoffs above 0.6 were highly likely to be the oncocytomas, versus those that were low on the relative uptake below 0.6 were more likely to be the cancerous ones. So that was very encouraging. And so here's some of the very impressive imaging. Starting from left to right, we see the standard CT of a kidney mass. And these are 3 separate examples. All of these are oncocytomas. And if you look at the SPECT CT image, in the second column, it's very, very dark. If you use the fuse imaging, it's bright. Okay, that means that it took up a lot of the sestamibi that was linked to the radioisotope, and you can see all the oncocytomas lit up. And this is a sharp distinction to the cancerous tumors that were all cold on sestamibi SPECT imaging. So again, this almost looked like the holy grail that could separate cancer versus benign. And they proposed that if you had a small renal mass, that we can use a combination of conventional cross-sectional imaging, add nuclear imaging, specifically SPECT sestamibi, to help risk stratify who is likely to have benign tumor versus a low-risk tumor versus cancerous tumor. Well, unfortunately, not so fast. As we know in medicine and science, things are not always perfect. So this is a group from Fox Chase that applied sestamibi SPECT in the real world setting in 72 patients with kidney masses. And unfortunately, the performance characteristics did not hold to be as accurate as the preliminary study, in that 60 tumors were cold on sestamibi SPECT, and you would expect those to be all cancers, and 20% of those actually had oncocytomas. And also, 11 had hot lesions, and these would all be expected to be oncocytomas. And indeed, 86% were oncocytomas and benign, but 14% had cancer. So clearly, further work needs to be done to define the role of sestamibi SPECT. So it's not quite ready to replace kidney mass biopsy, and is not the holy grail that we are hoping. Now, another type of molecular imaging is girentuximab, and this is a monoclonal antibody, a chimeric IgG1 monoclonal antibody directed against a target called carbonic anhydrase 9, or CA9. It used to be called G250. And this is a membrane-based target that is very highly expressed in over 95% of clear cell kidney cancers. Again, so this is, can we capitalize on targeting this to identify those that are the most common and most malignant kidney cancer, clear cell renal cell carcinoma. And if you look at the staining, CA9 is highly staining positive for the clear cell, which is the top panel, versus other types of tumors like papillary. This is the second most common type of kidney cancer, which has very little to no staining. So this is very specific to clear cell renal cell carcinoma. So there was a study that came out not too long ago in 2013, where there was a multi-center prospective image and resect study, meaning they imaged these tumors with PET imaging directed to CA9 using girentuximab, and then they went and resected them to have direct comparison between the image and the pathology. And they these images were read by radiologists and pathologists that were blinded to the study, and they found that if you look at the middle column, if you use the PET CT combination, okay, using girentuximab, it really improved the performance characteristics of identifying those that were kidney cancers, specifically clear cell kidney cancers, as compared to conventional cross-sectional imaging alone, which is the right-sided panel, where the performance characteristics were not as high. So this was really promising in identifying those that are clear cell. And again, here is some imaging examples. On the left, a clear cell renal cell carcinoma that lit up very nicely with girentuximab on the PET imaging versus an oncocytoma tumor that is cold. And now what people are doing is adding different types of radiolabels. So instead of using I-124, can we conjugate CA9 to zirconium, which appears to improve cytoplasmic retention, and maybe that would help improve the performance characteristics of PET imaging even further. And this is currently Zircon, which is a study that is a worldwide study, large scale, 300 patients, 9 countries involved, and hopefully we'll see results come out from the study soon, and that may benefit our clinicians. So future directions, if we take an indeterminate small renal mass, can we somehow use a combination of sestamibi and CA9 PET imaging to really segregate those that are clear cell versus the other variants? And so more to come, and that may be a future direction. I will end my study on optical imaging, which is a subject matter that I'm fascinated with. optical imaging, if you remember from our high school physics, light, white light is, a very large spectrum of wavelengths of light, as we know. And if we think about how light interacts with tissues in the real world, our eyes and our brains can interpret that information as data, if you will, right? And that's how we see the real world. Well, similarly, optical physicists can utilize this concept and say, how can light interact with tissues, and can we capture that information to provide information? So we can take it further in the concept of this study. Can we capture light-based reflectance or absorption or scattering patterns to differentiate tumors and provide essentially a histologic equivalent? One such technology is optical coherence tomography. And this is a high-resolution cross-sectional real-time imaging that looks specifically at surface and subsurface layers in architecture. So it's similar to ultrasound, but instead of sound waves, it uses near-infrared light. And the bottom line is the table, unlike CT and MRI, that gives us, gross or a large organ level of information, and ultrasound maybe some macroscopic level of information. OCT provides what the term is mesoscopic information. So it's a higher resolution than the other two types, but provides information on tissue layers and architecture and structural organization. So this is a unpublished study. This is a colleague of mine in Amsterdam that utilized a technology called OCT, and is a helical OCT that really sends essentially, near-infrared light in a circular fashion, almost like a lighthouse, to gather information. And this is some of the imaging that can be obtained. On the left side, this is the helical OCT. On the right side is the ground truth histology. And you can start to see the characteristic tissue pattern looks very, very similar. Taking it further, you can derive quantitatively a signal called optical attenuation coefficient from OCT, and this can be a quantitative value that can be expressed. And then they determine not only can we look at some visual characteristics, but we can also use this optical attenuation to help determine which is likely to be a kidney cancer or renal cell carcinoma, which is higher optical attenuation coefficient than the benign tumors, oncocytoma, which have lower attenuation coefficient. So again, suggested that this could potentially tell us one versus the other. Now, taking one step further, beyond OCT is a technology called confocal laser and microscopy. And some of the audience members who work in a basic science lab are very familiar with this. This is a high-resolution, real-time optical imaging similar to OCT, but a high resolution, because it basically helps filter out a very, very defined in-focus plane of tissues of reflected light. But it does require the additions of a fluorescence probe to augment the signal. And so this is, instead of near-infrared light, we're using backscattered, or we're acquiring backscattered fluorescence light. So if you put OCT, CLE next to each other, OCT provides mesoscopic level information, whereas CLE provides microscopic level of information, so at a much higher resolution, really giving us information on the cellular and subcellular architecture level. So again, these are the benchtop systems in basic science labs, and if you walk down the corridor of any basic science lab, you see these beautiful pictures of cells, right, that are all fluorescent. These are oftentimes performed by benchtop confocal laser and microscopy systems. Well, from a surgical standpoint, these are also systems available in a fiber optic delivery format. These are fiber optic probes that emit 488 nanometer laser excitation, providing very high resolution dynamic imaging of surface and subsurface imaging. And this is currently being widely used in pulmonary medicine as well as gastroenterology, where they can pass these down scopes during bronchoscopy or colonoscopy to touch different tumors and different abnormalities to determine what they are, even without doing a biopsy. So it occurred to me, if that can be done, can we do the same thing with kidney tumors? Can we devise or utilize this technology and, on a contact basis, provide a minimally invasive technique, not penetrating the tumor like we do with renal mass biopsies, but by contact, can we provide a histological equivalent using this technology? And that was the idea behind a study that we later published in 2016. So this is a series of patients that were undergoing partial nephrectomies already because of concern of a small renal mass that may be kidney cancer. And so when we removed these ex vivo, we then applied confocal laser endomicroscopy as a proof of concept. And we imaged both the surface of the tumor, as you can see in the top picture, but we also bivalved the tumor and looked en face directly on the tumor. And the reason we did that is, unfortunately, to our disappointment, when we tried to image the tumor on the surface, we found that the image quality was very limited. And that is because these tumors have a capsule. And these capsules, or pseudocapsules, are thick enough that it did not allow the light excitation to penetrate deep enough to get enough signal back in reflectance to be able to provide an image. So that is the limitation of light imaging technologies. You know, the higher resolution, the more limited the depth of penetration. So that was really the problem that we were facing in utilizing this to derive a contact non-invasive optical biopsy, if you will. But instead, we looked at the en face imaging to say, well, what would it look like if we did penetrate the tumor? And we did en face imaging. Site-specific samples were taken to allow for co-registration between what we were seeing on confocal to ground truth histology. And here is a quick video of what this looks like. So this is the tumor on the back table after it's been removed. It's been bivalved, stained with fluorescein. Remember, I said we have to add a fluorescence probe, and you can see the image on the screen that we're looking at. We get these nice, beautiful images, and I'm going to show you some of this in more detail in a second. So here's normal kidney on the left by histology, and on the right, here are the beautiful images, and that we were very excited to see that actually were very similar side by side to histology. You can see tubules, you can see the glomerulus, which is the structure that filters blood in the kidney. And so we are very encouraged that CLE, at least on the en face imaging, really provided very similar imaging characteristics or optical histology equivalent to what we see in ground truth histology. Also, we looked at the benign tumors. On the top panel is a tumor called angiomyolipoma, and the lipoma content is these big fat globulates you see in white on the histology, and they were staining very dark in the confocal study of confocal image because fluorescein does not penetrate into fat cells, and so you can see very similar architectural characteristics. In the oncocytoma, you can see the clustering of the cells that were very similar to what we see in the histology. Now, unfortunately, when we looked to the cancer subtypes, we did not see as similar appearance as what we saw in histology. We did some studies on papillary, which you could see some papillary architecture, but the clear cell, which is really the one that we want to know a lot more about on imaging, was really a sea of gray kind of fuzzy cells. And that's because later on we realized that fluorescein, as it dies, not picked up by all cells to the same degree, and therefore we could not highlight those cells as well as we could in some of the other subtypes, or certainly the normal kidney or the benign tumors. But nonetheless, we've created a very extensive library of what confocal laser endomicroscopy looks like for cancerous kidney tumors, benign tumors, non-neoplastic tissues, such as the capsule of the kidney, the pyramids of the kidney, the sinus fat, the collecting system, even the surrounding adrenal gland, to begin to have this as a point of reference for future studies in this particular arena. So, in conclusion, I think the field of advanced imaging for small renal masses, kidney tumors, is extremely active, and forgive my pun, the word bright, because I think there's a lot of opportunity that hopefully you see that I presented today. And this spans cross-sectional imaging, molecular imaging, optical imaging, and throughout all this, the overlying possibility of artificial intelligence and machine learning may be able to enhance some of what I've already presented today. And urologists need to work alongside our radiology colleagues and computer scientists to really advance this field, because there's a lot that we can do. And if we can find improved imaging, many of these advances will likely very effectively shape clinical practice and improve preoperative risk categorization for patients that present to our office that have small kidney tumors. It may help reduce unnecessary renal mass biopsies. It can improve appropriate clinical decision making, and probably most important, reduce the unnecessary treatments and the cost for patients that end up having benign tumors. Well, I thank you for this opportunity to speak to you today, and hope that this stimulates some of you to consider what you can do in your separate fields to enhance this knowledge and inform us to improve patient care. Thank you very much for this opportunity.
Thank you again, Li-Ming Su, for your time today and your important research. Before we go, I'd like to thank the audience for joining us today. Questions submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand for 2 years until October 5, 2025. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.